The hardest thing that we deal with now is patients who don't respond at all to a PD-L1 inhibitor or respond and benefit to a small extent and then progress. Options there are quite limited. Of course, if they haven't had chemotherapy, one should use chemotherapy. A number of interesting presentations here at ASCO where people have quantitated their approach, and the response rates do look minimally higher for chemotherapy in that setting versus chemotherapy without immunotherapy first. No, you would want, I think, in the best of cases, to understand what is the reason for the refractory disease. Are there regulatory T cells in the tumor? Is there a lack of inflammation? And if you understood that, you could perhaps think about immune combinations that might work in that setting. There'll be a host of clinical trials in the next few years to deal with that. But chemotherapy, or even chemotherapy with an immunotherapy at that point, would probably be the standard of approach. Anti-VEGF antibodies we use mostly with chemotherapy, so we're not using as many of them. The place where we're using the anti-VEGF antibodies, that would be bevacizumab. Now would be in combination with immunotherapy. Some of the trials with atezolizumab now are looking at bevacizumab. Also, by the way, you can block VEGF with small molecule inhibitors of VEGFR2, such as ramucirumab. I've been quite intrigued by the combination of pembrolizumab and ramucirumab, which is a phase 1/2 trial that I've actually led. In 24 patients with lung cancer, we've seen response rates in the 30% range, including large responses in patients that don't have PD-L1 positivity and a median progression-free survival of almost 10 months in a second to fourth line setting. What does that mean? I think that when you use an angiogenesis inhibitor, I think there is some effect on dendritic cells and antigen presentation. There is some effect on bringing T cell into the tumor. So I think this is something that needs to be further explored. Sequencing of immunotherapies is the future. How are we going to treat a tumor, see the best effect? If a patient doesn't respond or responds and then the tumor grows again, we are going to need to think about how to really harness all the power of the immune system, not just the PD-1, PD-L1. We see that, at the ASCO meeting, we saw hundreds of posters about different combinations and approaches, ways to alter the tumor microenvironment to make the tumor more sensitive to checkpoint inhibition, ways to bring immune infiltrate into the tumor. All these things are really ripe for the picking. We need more clinical trials, research, but these are options that are all available to patients as we learn how to do this best.
With the approval of immunotherapy in the frontline setting and the availability of immunotherapy in the second-line setting for patients that did not receive it as frontline therapy, we have seen a significant change in the use of chemotherapy and chemotherapy in combination with VEGF inhibitors. What used to be our frontline therapy has frequently moved to the second line, and what was a second-line therapy has moved to the third line. There are no specific recommendations regarding any modifications in these regimens when they're used as second or third-line regimens, and we continue to use them on all patients that make it to these lines of therapy. In my practice, the majority of the patients that progress after immunotherapy are being considered for clinical trial participation. However, for the patients that are being treated with standard of care, my recommendation is standard chemotherapy or combination of chemotherapy and a VEGF inhibitor. The data that we saw at ASCO in 2017 suggests that chemotherapy's activity post-progression from an immunotherapy agent may be slightly higher than what we were previously experiencing in this setting.